Let's talk about colon cancer, the third most common cancer in the world after breast cancer and prostate cancer for men, as well as lung cancer. It's also the third most common cause of death from cancer. So colon cancer is a big deal both for men and women. And the major risk factors include age. Anybody over 50 should be getting screened. High fat intake in the diet. A diet low in fiber. If you have polyps in your colon, polyps progress to colon cancer, even benign polyps. And inflammatory bowel diseases like ulcerative colitis and Crohn's disease cause chronic inflammation. Chronic inflammation anywhere can end up leading to cancer. A family history, especially familial polyposis colon cancer, and Lynch syndromes. FBC would be the extreme version. Usually, you can almost guarantee a colon cancer by the age of 30 or 40. So these people are going to walk into a primary care office or sometimes an emergency room with an acute change in bowel habits. Sometimes that can also be kind of a chronic change. With bowel obstruction due to a colon cancer, you can get some serious abdominal pain, or with a less acute obstruction, you can get just abdominal discomfort over time. Weight loss can result from malabsorption and also just for general GI discomfort, which may cause anorexia. Anemia will show up. Any anemic person over the age of 50 should certainly be getting a colonoscopy to check for some kind of colon cancer. And then blood in the stool. And blood in the stool will present kind of on a gradient. If the bleed is in the right colon or the proximal colon, it's going to come out kind of brown after it passes through the anus. In the transverse colon, you get kind of a reddish brown, and then that bright red blood would be an indication of bleeding in the rectum or the left descending colon. So anybody with bleeding from the rectum, you've got to rule out some kind of a colon cancer. When you do an exam, of course you want to inspect the abdomen. You want to rule out causes of their discomfort due to prior surgery, so you look for any kind of an incision site. Also check for Virchow's node. You listen, and generally the loss of bowel sounds is not going to be seen in a chronic condition, but if you've got an acute abdomen, you may hear some lack of bowel sounds. You want to percuss to figure out the size of the liver, as well as just to hear for fluid in the abdomen, and palpate, see if you can feel any masses. On the rectal exam, first inspect the anal area. Sometimes you can have lesions coming out of the anus that you can actually see. You on a digital rectal exam, you will feel, you may be able to feel a lesion if it's close enough to the anus. And then as you pull your finger out, you do a fecal occult blood test. If it's a male, you also want to do a prostate exam while you're in there. And then if you have it available, you can do anoscopy and just take a look in the rectum. So laboratory tests are useful. They may help you to see perhaps an anemia that might give you an indication that you want to get some more imaging done. But also just for pre-op, if you want to make sure that somebody is available for, or not available, but a candidate for operation, assuming that you've already gotten imaging that shows that you have something that needs to be resected, then a CBC chemistry profile. You want to make sure that they're not going to bleed too much, so you check the PTT. Do a urinalysis just to make sure that they don't have any kind of an infection. And liver enzymes may or may not be helpful. They're not going to be as sensitive as actually imaging the liver to see if we have metastasis. After you do an operation, one of the best indicators of recurrence is going to be your carcinoembryonic antigen. The CEA is not sensitive for screening, but it is it's going to be present in an elevated level. Will be present in around 85% of those with recurrence. So it will give you a good indication that you need to get a CT scan and check for recurrence. So colonoscopy is the gold standard in imaging the colon to look for lesions. It is the major screening test, and it also is helpful because on colonoscopy you can also do a resection of polyps and help prevent benign polyps from progressing into malignant ones. And of course you can take biopsies when you do colonoscopy too. The CT scan is helpful for staging of a known cancer. Helps you to identify metastases. The chest x-ray is good, especially if it's a rectal cancer. You can rule out metastasis to the lungs. And it also may be used in a preoperative situation just to rule out serious cardiopulmonary problems that may interfere with anesthesia. Some sigmoidoscopy is not as sensitive of an exam, but it's also a lot less expensive, and it's somewhat less invasive as well. You don't have to get anesthesia for sigmoidoscopy, so it could be done in for example, a primary care office or a GI doctor's office, and so those benefits may make it easier for people to get screening done. Even though it's not a complete screening, it's better than nothing. So if for whatever reason it's not easy to get somebody to get in to get screened, a sigmoidoscopy may help that situation. In a similar way, virtual colonoscopy may be used in patients who are not candidates for colonoscopy. You know, if they can't tolerate anesthesia, or if there is a high risk for perforation or bleeding, then the virtual colonoscopy is actually a sensitive exam that's still being developed, but it's been used for a few years now. And so patients that can't get a colonoscopy, a virtual colonoscopy might be a good idea, but it's currently not reimbursed as a screening modality. An endorectal ultrasound is also helpful for seeing invasion of cancer. You can use it to help determine the depth of some of the cancers that you may see on a colonoscopy. So there's some major differences between the colon versus the rectal cancer, and so that's one of the most important questions to ask or to find an answer to when diagnosing a colorectal cancer. One of the reasons is because colon cancer will metastasize to the liver predominantly as it goes through the portal cable system, and the liver is the first capillary bed that it will meet. Whereas the rectum is drained both by the portal cable system as well as just the inferior rectal veins, which will first go to the inferior vena cava and into the heart and lungs, so that the lungs is one of the major places of metastasis for the rectal cancers. It also is going to affect resection just because it's easier to get into the colon and get a margin on either side, whereas the rectal cancers, you may not get a 5 centimeter margin like you can get easily in the colon. And so you may end up having to do a more extensive surgery in order to get the margins you need.